There are a number of factors we consider when we decide whether a patient should be considered for single-agent hormone therapy or combination hormone therapy, also for chemotherapy. The two main things we take into consideration is the disease activity and what we think is the endocrine sensitivity. Disease activity means what sites of disease when the patient relapsed, whether it's very active disease or slowly growing disease, whether it's bone metastasis versus visceral metastasis, whether there's a large degree or huge tumor burden in for example, in liver or lung, whether the patient has symptoms when this occurred relative to previous therapies. In terms of endocrine sensitivity, we take into consideration whether we think the patient has primary or acquired hormone resistance, or whether the patient in fact may have never seen endocrine therapy, and therefore the tumor is more likely to be endocrine sensitive. We also take into consideration some of the information on the biology of the tumor, like proliferation rate measured often by Ki67, also the progesterone receptor. These are all relatively soft markers, and there isn't a clear cut for any of these markers where we say with this you definitely have to have single agent hormone therapy, or with this definitely combination therapy. But if you amount all of this information together, we can come up with patients who we consider are at relatively low risk of failing to single agent hormone therapy, and those patients can be considered for single agent endocrine therapy, whereas if patients who have a more intermediate or higher risk of failing to single agent endocrine therapy should probably be considered for combination endocrine therapy, or in some cases for chemotherapy. It is a challenge and remains a challenge for us to make this decision process objective. There are no black and white criteria where we say this is the cutoff from this time point on, we need to decide this patient has combination endocrine therapy. I think part of it is learning from experience which patient groups benefit most from what type of treatment. We will also have to see whether there's a survival benefit associated with combination endocrine therapy, because that will clearly steer us more towards giving combination therapies earlier on. In the absence of a survival benefit, we need to try to use all the available information, for example molecular information such as ESR1 mutation status, to make it more objective, but there will always be an element of subjectivity in our decision process.